name is Paulus Kirchhof. I'm a cardiologist from the University Heart and Vascular Center Hamburg in Germany, and I'm here in Amsterdam during the annual Congress of the European Society of Cardiology 2023. We just published and presented the results of the non-vitamin K antagonist oral anticoagulants in patients with atrial high rate episodes trial here in Amsterdam and published it in the New England Journal. And I'm here to tell you a little bit of why we did the trial, what the outcomes were, and how we think it may actually affect your practice. Let me start with the headline finding. Non-vitamin K antagonist oral anticoagulants, blood thinners, are not effective in patients with atrial high rate episodes, even though these episodes look like atrial fibrillation. Rather, they induce bleeding, and therefore, and I think this is good news for our patients, we do not need to treat patients with these rare device-detected atrial arrhythmias with blood thinners. Now, why did we do the trial? You all know that blood thinners, anticoagulants, prevent strokes in patients with atrial fibrillation, and we therefore prescribe them to those patients increasingly, and we can prevent many strokes and help our patients. Atrial high rate episodes are short and rare atrial arrhythmias that look and feel like atrial fibrillation, and they are picked up by implanted devices, pacemakers, defibrillators, CRT devices, or implanted loop recorders. Because these episodes look and feel like atrial fibrillation, many of our colleagues start blood thinners, anticoagulants in these patients. But the efficacy and safety of anticoagulation in patients with atrial high rate episodes has never been tested. The German AFNET therefore joined forces with the German Center for Cardiovascular Research and with Daiichi Sankyo Europe, who provided money for this investigator-initiated trial, to conduct the NOAA-AFNET 6 trial. In the trial, over 2,536 patients with atrial high rate episodes lasting 6 minutes or longer, aged 65 years or older, and with one additional stroke risk factor if they had atrial fibrillation, were randomized to either no anticoagulation or anticoagulation in a double-blind, double-dummy design. No anticoagulation consisted of a placebo, and the treatment contained aspirin in those patients with an accepted indication for aspirin. Anticoagulation consisted of the edoxaban in the dose approved for stroke prevention in patients with atrial fibrillation, and an aspirin dummy not containing aspirin. The primary outcome was a composite of stroke, systemic embolism, or cardiovascular death. The safety outcome was a composite of major ISDH bleeding or death. The trial was stopped prematurely due to expected safety events and the trend towards futility. And we now published the main results. Anticoagulation does not reduce a composite of stroke, systemic embolism, or cardiovascular death in patients with atrial high rate episodes and stroke risk factors. There were 83 patients with a primary outcome event in the patients randomized to edoxaban, and 101 in the patients randomized to placebo. This was not significant at a p of 0.15. Importantly, and unexpectedly to us, the stroke rate was very low in both randomized groups, 1.1% per year in the patients randomized to no anticoagulation and 0.9% per year in those randomized to placebo. Primary safety outcome occurred in 149 patients randomized to anticoagulation and in 114 randomized to no anticoagulation. And this difference was statistically significant and mainly driven by an increase in major bleeding events, which you would expect with every anticoagulant. About 9% of patients per year developed ECG-diagnosed atrial fibrillation and were taken off study medication and on open-label anticoagulation as per current guidelines. So, in conclusion, patients with atrial high rate episodes but without ECG-documented atrial fibrillation do not need blood thinners, anticoagulants, because their stroke rate is already low without treatment. Anticoagulation does not further reduce cardiovascular thrombotic events, but as expected, increases bleeding. We performed several sub-analyses in the trial, including looking at the effect of the duration of the atrial high rate episodes or of the number and severity of stroke risk factors, in addition to age and sex and the indication for aspirin, and there was no interaction with the treatment effect. There is one other trial that will probably report soon. It's called Artesia, and it compares a very similar intervention, anticoagulation with apixaban, to aspirin given to everyone in a very similar population. We will probably be able to learn a lot more about the factors that are associated with stroke and other cardiovascular events in patients with atrial high rate episodes. Because until we have done these analyses, the current conclusion, based on this first randomized trial ever of this intervention in the population with ARIA, is that we can safely withhold anticoagulation until ECG-documented atrial fibrillation develops.